Hello, my name is Neil Iyengar. I'm a breast medical oncologist, co-director of the Breast Medical Oncology Program and director of the Survivorship Service at the Winship Cancer Institute of Emory University. I'm delighted to be joined by Dr. Ticiana Leal, an expert in lung cancer treatment. Ticiana, I'll let you introduce yourself.
Yes, my name is Ticiana Leal. I'm a professor and director of our Thoracic Oncology Program and medical director of our Clinical Trials Office at the Winship Cancer Institute at Emory here in Atlanta, Georgia. Happy to be here today to discuss this important topic.
Great, thank you. So we'll start by just generally talking about antibody-drug conjugates, or ADCs, and how they've really made a mark in cancer therapeutics. And I think it's really exciting to be able to have this cross-disciplinary conversation across two different cancer types. Really tells us a little bit about how the treatment evolution has been impacted by ADCs across cancers. Certainly in breast cancer, the ADCs have been remarkable in terms of improving outcomes, and even in terms of quality of life and tolerability of therapies. I think we've now seen multiple studies with multiple approvals of antibody-drug conjugates that not only improve efficacy endpoints like progression-free survival and even overall survival, but patient-reported outcomes, as well as more tolerable adverse effect profiles when compared to standard chemotherapy. And I would say certainly in breast cancer, we're moving to a place where the ADCs are replacing standard chemotherapy, at least in earlier lines of therapy, in hormone receptor positive breast cancer, in HER2 positive breast cancer, and now even in triple negative breast cancer. I think the ADCs have been a welcome advance. Now, what we're struggling with, of course, is how to sequence the ADCs, how to optimally select patients for ADC treatment, and several other topics that we'll discuss today. But I wanted to get a sense from you whether you're seeing similar evolution in lung cancer therapy and how generally ADCs have impacted the lung cancer world.
Yeah, I think ADCs are now a part of our standard of care in subtypes of non-small cell lung cancer. Specifically, we've seen these move already into the clinic for patients with HER2 mutations, non-small cell lung cancer, with Trastuzumab Deruxtecan. This was our first actual targeted therapy because this targets HER2 for these patients, and it was a really big unmet need. So that has been an amazing advance for our patients. In addition to that, we've also seen HER2 ADCs also move into the space of previously treated patients with HER2 IHC expression 3+. And then lastly, we've also seen them move into the previously treated space for patients with EGFR non-small cell lung cancer with Datopotamab Deruxtecan. I think the challenge here is going to be sequencing within the options that we have, but we're not yet facing the problem of sequencing ADCs in non-small cell lung cancer. And then we'll talk about this later on in future directions, but we have several ADCs that are actively being developed for patients with small cell lung cancer as well.
Exciting. So a lot to put into context here. Maybe we'll start at the beginning of all of that and talk a little bit about some of the efficacy data supporting ADC use. And I think we were both alluding to this in terms of comparison with chemotherapy or traditional chemotherapy. In the breast cancer world, we've now seen several phase 3 trials that have led to the registration of several ADCs that have compared these ADCs with chemotherapy. You mentioned HER2 targeted ADCs, Trastuzumab Deruxtecan, and certainly Datopotamab Deruxtecan, another ADC that targets TROP2, are now approved in breast cancer therapy. And I would say specifically with regards to our newest one, Datopotamab Deruxtecan, or DATRAWAY, we've now seen phase 3 trials that have, in hormone receptor positive breast cancer, have established Dato-DXd as superior to chemotherapy in hormone receptor positive disease after endocrine therapy resistance. And of course, I appreciate that this is very different than lung cancer sequencing, but certainly in breast cancer, where we're really trying to exhaust our endocrine therapies first, I think the big question for some time has been, after we move into chemotherapy, do we really need to go to chemotherapy first, or can we go to an ADC first? And that question is being addressed. But in the TROPION-Breast trial, what we saw that was after 1 to 2 lines of chemotherapy, ADCs were superior to standard chemotherapy. So our traditional sequencing approach after endocrine therapy is to use a line of chemotherapy. I typically use Xeloda or capecitabine, and then we'll move into something like Datopotamab Deruxtecan. Now, this is assuming that the patient is not eligible for a HER2-targeted ADC like T-DXd. We'll come to that sequencing question later. But from an efficacy standpoint, I think we've all been very pleased in the breast cancer world to see a superior treatment option compared to standard chemotherapy, Datopotamab Deruxtecan over standard chemotherapy. And now we have data in triple-negative breast cancer, potentially placing Dato-DXd in the first-line treatment. In TROPION-Breast02, we saw the superiority of Dato-DXd over standard chemotherapy in patients who are treatment naive in the metastatic setting for triple-negative breast cancer. So I think this is a rapidly evolving space, and certainly the ADCs we're using more and more. Could you walk us through what you're seeing in lung cancer?
Yeah, so specifically thinking about patients with non-small cell lung cancer, there was a major phase 3 trial, TROPION-Lung01, where patients with non-small cell lung cancer and both squamous and non-squamous histologies were permitted, and patients with actionable driver mutations after previously receiving targeted therapy, they were randomized to Datopotamab Deruxtecan versus docetaxel. And in that study, what we saw was that there was improvement in progression-free survival. It did meet statistically significance. It was modest, mostly driven by the non-squamous population. However, the overall survival was negative. So what ended up happening with that study is they created a second analysis where they pooled patients from 2 studies, TROPION-Lung01 and TROPION-Lung05. TROPION-Lung05 was a single-arm phase 2 trial that included patients with actionable driver mutations that had previously progressed on their targeted therapy, and these patients received Datopotamab Deruxtecan. So here we have a pool of patients from these 2 studies. We had about 117 patients with EGFR mutation, non-small cell lung cancer. And what we saw there was high response rates in this previously treated population. So these patients received prior platinum, prior osimertinib, and now we're receiving Datopotamab Deruxtecan. So a huge unmet need area there for our patients with EGFR, who tend to be younger, healthier. These patients do need later lines of therapies after progression on osimertinib and chemotherapy. We saw response rates of 40%. We saw a PFS of about 5 months and an overall survival about 15 months. This really leading to approval of Datopotamab Deruxtecan in patients with previously treated EGFR non-small cell lung cancer. An additional, I think, advantage of Datopotamab for this patient population was the CNS activity that was demonstrated. Patients with EGFR, unfortunately, have high risk of relapse in the brain. And so having an agent that was demonstrated in these studies, in this pooled analysis, to have response rate of 40% was also another welcome addition in terms of how we treat and manage this disease.
Fascinating. I mean, it's really interesting to look across cancers and see this activity. And I'm so glad you raised the CNS point, because we struggle with this in breast cancer as well, and particularly triple-negative breast cancer. We have less data guiding us in terms of the CNS activity of ADCs in general, although I will say that with the caveat of T-DXd in HER2-amplified disease, we've got, I would consider, pretty robust data demonstrating CNS activity. But for triple-negative breast cancer, most of our data is post-hoc or largely observational, and so I think it's reassuring to see the lung cancer data for an ADC like Dato-DXd, and hopefully that will translate to triple-negative breast cancer as well. But we've both been alluding to where, or the optimal sequencing approach for ADCs and for Dato-DXd, and this has been a challenge, I think. In the breast cancer world, it's been a challenge because we have other ADCs as well. I think from a chemotherapy versus ADC sequencing question, we now have ample evidence that the ADC typically should either precede chemotherapy entirely, or after 1 to 2 lines of chemotherapy, it's reasonable to move to an ADC. I think in the setting of HER2 low or HER2 ultra low disease, or breast cancer specifically, we have the option of using Trastuzumab Deruxtecan, and we've now seen the DESTINY-Breast04 and the DESTINY-Breast06 trials, which have shown the superiority of T-DXd over chemotherapy for HER2 low and DB06 showing activity for HER2 ultra low disease. The additional knowledge we gained from DESTINY-Breast06 was this trial tested T-DXd in a more frontline setting. So these were patients who had received endocrine therapy and then went on to the trial before receiving chemotherapy in the endocrine resistance setting, and we saw the superiority of T-DXd over standard chemotherapy there. So I think from a sequencing standpoint, when I'm thinking about a patient with hormone receptor positive metastatic breast cancer, I'm thinking about whether or not they're HER2 low or ultra low, and if they are, reaching for T-DXd after we've exhausted endocrine therapy. If they are not HER2 low or ultra low, in other words, if they're HER2 null, so no membrane staining at all, then I will likely use a line of chemotherapy like Xeloda and then move on to Datopotamab Deruxtecan. Now the question is, if they're HER2 low and ultra low, when can I use Datopotamab Deruxtecan? And I think this is where we have observational data sets which demonstrate that when you're sequencing two ADCs, whichever ADC you use as your subsequent ADC is likely to have less activity than the first ADC that you used. Now, whether that's because you've advanced in your lines of therapies or whether that's because the first ADC is truly engendering some kind of resistance to the subsequent ADCs, I don't think we know the answer to that. I do suspect it's because of the natural history of the disease and moving to the next line of therapy. But in the hormone receptor setting, there's some evidence to suggest that sandwiching a chemotherapy in between the ADCs might increase the efficacy of the subsequent ADC. So I tend to do that if I use T-DXd first, then maybe a line of Xeloda next, and then go to Dato-DXd. But in the triple negative setting, where we have limited treatment options, I have sequenced ADCs back to back. And typically we'll use a TROP2-directed ADC in the first line, like Dato-DXd, and then if they are HER2 low, then I will consider using T-DXd as a subsequent line of therapy. Now, I understand it's a bit different in lung cancer, where I don't think all of these ADCs are yet quite available, but you do have to consider sequencing with other lung cancer-directed therapies, is my understanding. So what are your thoughts about this?
So specifically, for example, thinking about patients with HER2 mutation non-small cell lung cancer. So 2 to 4% of our patients with non-small cell lung cancer, majority are adenocarcinomas, have identification of HER2 mutations on next-generation sequencing. And so Trastuzumab Deruxtecan was our first targeted therapy for patients with HER2 mutations. Typically, the paradigm was chemotherapy with a platinum-based chemotherapy with pemetrexed plus minus immunotherapy. Prior data really has shown that immunotherapy does not seem to have efficacy in patients with HER2 mutated non-small cell lung cancer. And we, would see that treating patients in frontline with platinum plus minus IO, you get very short PFS, shorter than what you would expect for a patient with non-small cell lung cancer. And I think another big issue was CNS progression as well. So the way Trastuzumab Deruxtecan was approved was based on the DESTINY-Lung02 trial and DESTINY-Lung1, where we saw the activity of Trastuzumab Deruxtecan at 5.4 milligrams per kilogram in these patients. Now the issue is it got approved in second line. And so I think we kind of, based on FDA approvals and NCCN guidelines, the recommendation is using first platinum-based chemotherapy followed by Trastuzumab Deruxtecan. There is, I think, a lot of enthusiasm to use it as a frontline because of the activity that we saw and CNS activity as well with Trastuzumab Deruxtecan. But the biggest challenge for us today is not with chemotherapy sequencing. Since we had the approval of Trastuzumab Deruxtecan, we also had approval of 2 TKIs targeting HER2. The first one was Zongertinib, which is a HER2 TKI. And then we also saw approval of Cevabertinib, which is an EGFR HER2 TKI. Again, all of these agents very active in patients with HER2 mutated non-small cell lung cancer. And then most recently in February, based on data from the BEAMIN-Lung1 trial, the cohort of patients that were treatment naive, again, showing excellent response rates, just amazing PFS, led to then approval of Zongertinib in frontline for patients with HER2 mutated non-small cell lung cancer. So now the biggest question is, how do we sequence HER2 TKIs? with Trastuzumab, Deruxtecan, and then certainly where does chemotherapy fit in? So I think the paradigm is quickly changing. I think it's a big advantage for our patients with non-small cell lung cancer with HER2 mutations, really meeting a really big unmet need. So right now, the way that I think the sequencing is that patients would receive zongertinib as frontline based on the FDA approval. And then the question is, do you sequence that then with Trastuzumab, Deruxtecan? And we're still going to learn more about what kind of resistance mutations we're going to see and how does that fit into the treatment paradigm. But I think that's the way that I interpret the data. I would use zongertinib first, Trastuzumab, Deruxtecan as a second-line agent, and then try and understand where cevabertinib fits into this treatment paradigm, as well as chemotherapy, depending on what we learn about resistance mutations. We are seeing a lot of these agents actually go to frontline versus chemotherapy. The confirmatory studies are ongoing, including for Trastuzumab, Deruxtecan, DESTINY-Lung04, which is chemotherapy plus IO versus Trastuzumab, Deruxtecan. So a lot of interesting data coming out, and I think we're like in real time. Real world data is going to be really interesting so that we understand sequencing. But we don't have yet the challenge of sequencing ADCs. But one thing I thought about what you were saying is, one of the issues could be the payload. Both Trastuzumab, Deruxtecan, and Datopotamab both have topo-1 inhibitor payloads. For us, Datopotamab Deruxtecan is in the space of EGFR mutated non-small cell lung cancer. Again, a lot of advances have been made in that subgroup of patients as well, because we now use chemotherapy with platinum plus pemetrexed in combination with osimertinib as frontline. This is the FLAURA2 regimen that showed improved progression-free survival, overall survival versus osimertinib alone. And importantly, we saw a really greater magnitude of benefit in patients with high-risk features, including p53 mutations, of course, brain mets, presence of ctDNA, liver metastasis. These are all patients that have higher risk of having shorter PFS on osimertinib monotherapy, and the majority of our patients have at least one of these high-risk features, including if you have an L858R mutation versus not. So we start with chemo plus OC, and then what comes in second line? Our old paradigm was osimertinib followed by chemotherapy plus amivantamab based on the MARIPOSA-2 study, but now we've sequenced chemotherapy first. So I think this is where Datopotamab could position itself as a second line agent for patients who receive chemo plus osimertinib, have progression. We have Datopotamab Deruxtecan in that space. However, there are certain situations where we may want to re-challenge patients with chemotherapy. And so we have data for MARIPOSA-2 in that setting where we would add chemo plus amivantamab. In that setting, that would, I think, push Datopotamab to third line. Or another option is the COMPEL data, which re-challenges people with chemo plus OC. Another sort of interesting sequencing that could occur is if patients receive amivantamab plus lazertinib as frontline. This is another regimen that we have that, again, showed improved progression-free survival, overall survival versus osimertinib monotherapy, also in patients with high-risk features. So really, the paradigm has shifted where combination strategies are the way to go for patients with EGFR mutated. But if you're using amivantamab, which is an EGFR MET bispecific antibody, plus lazertinib, which is an EGFR TKI, thereafter, I think chemotherapy would fit, and Datopotamab Deruxtecan then I think would go third line. So the sequencing for us really has to do with how did they do on their prior regimen, and what was the option for frontline. So very interesting, but certainly I think really an important space for us to continue to explore what is the optimal sequencing of these agents.
That's really interesting. It's while we're all, dealing with ADC sequencing a bit, you also have all these other targeted therapies that you're thinking about. And while you were mentioning some of these really important points, I was thinking, from an efficacy standpoint, one of the challenges that and it's actually not a challenge, it's a good thing that we face in breast cancer is we now have two TROP2 directed ADCs, Datopotamab Deruxtecan, which we've been talking about, but Sacituzumab govitecan as well. And we're going to talk about toxicity next, and I think one of the main ways that we're able to address both treatment selection and even sequencing is to think about not just the efficacy, but the toxicity profile as well. And the way that I think about the ADC treatment selection for breast cancer is first in thinking about efficacy and just clinical trial design, in hormone receptor positive breast cancer, we've been talking about Datopotamab Deruxtecan based on the Tropion-Breast trial, but we also have the TROPiCS-02 trial, which led to the registration of Trastuzumab govitecan, another TROP2-directed ADCs for hormone receptor positive breast cancer. But the key difference here is that the TROPiCS-02 trial was a later line trial. There were more lines of chemotherapy required in TROPiCS-02 than there was in Tropion-Breast. And so, when I'm thinking about sequencing, if I have a patient who has done one line of chemotherapy after endocrine therapy, I will likely, if I'm not using Trastuzumab Deruxtecan as my next line of therapy, or as my first line of therapy, then I will likely go to Datopotamab Deruxtecan just because of the differences in the trial design. And then in triple-negative breast cancer, we also have Trastuzumab govitecan as an option now in the front line, and Tropion-Breast-02 demonstrated the efficacy of Datopotamab Deruxtecan in the front line, and I think that's where we also really need to factor in toxicity as a consideration. The adverse effect profiles between these two ADCs are quite different, and then other practical measures like timings. For example, Trastuzumab govitecan is dosed on day 1 and day 8 of a 3-week cycle, whereas Datopotamab Deruxtecan is given every 3 weeks. So for some patients, it may be easier to stick with that every 3-week schedule. From a toxicity standpoint, Datopotamab Deruxtecan, we really need a proactive patient, a patient who is willing to partner in their treatment and participate in some of the prophylactic approaches that we take, which I'm assuming are similar in lung cancer. So just to review that briefly, patients need to do lubricating eye drops, I would say at least 4 times a day, as well as a steroid or dexamethasone mouthwash to prevent keratitis and to prevent mucositis, respectively. And what I find is that these approaches are actually really quite effective if patients are willing to do them and are able to be adherent to these approaches. From a management standpoint, what I find is that myelosuppression is less of an issue with Datopotamab Deruxtecan. So when I'm trying to make that treatment decision, particularly in triple-negative breast cancer, where we use a lot of myelosuppressive agents, if a patient has been struggling with cytopenias and neutropenia specifically, this may push me towards selecting Datopotamab Deruxtecan. Also, we see less GI toxicity with Datopotamab Deruxtecan. Diarrhea can be an issue with Trastuzumab govitecan, so if I have a patient who has underlying bowel disorders or just has struggled with GI toxicity, that would push me towards Datopotamab Deruxtecan as well. Now, on the flip side, we've talked a little bit about the eye prophylaxis, but corneal deficits is a contraindication for using Datopotamab Deruxtecan, and so that might push me towards selecting Trastuzumab govitecan in that setting. We know for Datopotamab Deruxtecan, patients need to see an optometrist or an ophthalmologist at baseline and then at least once a year for a checkup. I think reassuringly, the toxicity here for the eye, these are ocular surface events, so we're not really talking about vision loss or deficits even. It's really dry eye and tearing that we're dealing with. So I think that the AE profile is quite manageable as long as we're proactive about it. Is this a similar approach that you take in lung cancer?
Yeah, it's a very similar approach, and I think the safety profile in lung mirrors what you're talking about. There's one thing that I think is specific for lung that we worry about is ILD. So we did see ILD in the studies with lung cancer patients. The majority of them were grade 1 and 2 in nature. There were no treatment-related adverse events leading to death related to ILD in the study, but we did have 1% grade 3 ILD events in the study. So we are monitoring patients actively for signs and symptoms of ILD, like cough, shortness of breath, changes in oxygen level, and certainly any radiographic changes of ILD. We're very accustomed to monitoring for this, so I don't think it's something that we're unfamiliar with, but I think that's something that we're still sort of making sure that we stay on top of with patients.
Good point about the ILD. So let's briefly talk about biomarker testing, and you brought some of this up already, so we've covered a lot of it, but I think that in breast cancer, we're not testing for TROP2. This is a pretty ubiquitously expressed surface marker, at least across epithelial cells, and so certainly for epithelial cancers, we do find activity and not needing to generally test for treatment selection. Now, of course, HER2 testing is critical because this helps us in terms of ADC selection, Trastuzumab Deruxtecan versus Datopotamab Deruxtecan, as well as the sequencing decisions that we were talking about. So I think just the standard IHC testing that we do in breast cancer for receptors tends to be adequate for giving us the information in terms of ADC selection. Now, in the HER2 setting, we've moved towards more sensitive and more quantitative assays to help us understand if this is true HER2 amplification, HER2 low, or even picking up those HER2 ultra low tumors, which would then make the patient a candidate for T-DXd. So I think that's been the major advance in breast cancer immunohistochemistry, is identifying that HER2 low and HER2 ultra low population. But otherwise, it hasn't really been burdensome in terms of biomarker testing for selection or for identifying candidates for Dato-DXd. What is your biomarker testing approach in non-small cell lung cancer?
Yeah, so for non-small cell lung cancer, it's really important to upfront at initial diagnosis that every patient gets broad NGS testing, ideally with RNA coverage as well, not to miss fusions. And that's the way we identify the HER2 mutation. So the HER2 mutation, that's a target for using Trastuzumab Deruxtecan. And we also identify EGFR mutations, which that's the target for using Datopotamab Deruxtecan. In terms of additional biomarkers, that's also really important is PD-L1 expression for patients that don't have a genomic driver for optimization in terms of immunotherapy, either alone or in combination. And then we also have IHC, where we test for the HER2 IHC. HER2 amplification is also something that's identified on NGS. Typically, we see that more so as a mechanism of resistance when patients are on targeted therapies, and we're still trying to understand, can this be a primary driver in non-small cell lung cancer? But then there's another important question in terms of Datopotamab Deruxtecan. We saw the benefit of Datopotamab in the subset of patients with EGFR mutations. But broadly, the question was, is Datopotamab Deruxtecan more effective in non-small cell lung cancer patients if there is a biomarker for the TROP2 ADC? So using IHC was not adequate to identify that subgroup of patients, but we've seen a really interesting biomarker emerge called the QCS-NMR, which is a digital AI pathomics biomarker that has been developed, and it does seem to select patients that are deriving greater magnitude of benefit, including progression-free survival. And so this biomarker is now being incorporated in all of the phase 3 trials that are trying to investigate the use of Datopotamab Deruxtecan, now even in frontline in combination with other agents. A very interesting study was just presented at ELCC in Copenhagen this year, showing that for patients with EGFR mutation, again, I think high expression of TROP2, there you don't seem to do the biomarker selection for TROP2. So for the EGFR patients, it really is an all-comer approach for use of the TROP2 ADC at this time.
It's really fascinating. Some similarities, but also some differences in the approach for breast versus lung cancer. So thanks for outlining that. Well, let's look to the future. I think the ADC space has been really exciting, and certainly in the breast cancer world, we are seeing continued development of ADCs. And I think you made this point earlier about the payload. We do currently have that challenge in breast cancer, and that is that the payloads for most of our ADCs are the same mechanism, right? That topo-1 inhibition. And so I'm excited about ADCs that are coming down the pipeline, which either have different types of payloads or even different targeting for the antibody. We're seeing bispecific ADCs being developed as well. But also, I do have to mention that one of the more practical lines of investigation addresses this sequencing issue that we've been discussing. And there are trials underway, for example, the Dato-DXd trial and the Series trial, which are looking at different sequencing strategies for ADCs in breast cancer. So I'm hoping we'll have more evidence, not just observational data, but prospective clinical trial data to address this ADC sequencing question in the near future. Can you tell us a little bit about what you're excited about for the future of ADCs in lung cancer?
Yeah, I think, we're still investigating combinations with ADCs. I think that's a very exciting area. When you think, for example, of, the patients with HER2 mutated non-small cell lung cancer, the question is, can you combine, in my mind, a HER2 ADC like Trastuzumab Deruxtecan with a HER2 TKI that's very well tolerated like zongertinib, and will that maximize efficacy with a manageable safety profile? Can you combine it with chemotherapy? Again, we're talking about how do we use the platinum as it's pushed out in later lines. There is a concern there about attrition rates in non-small cell lung cancer. It is a very aggressive disease, and so can we maximize efficacy in earlier lines and combine Trastuzumab Deruxtecan with chemotherapy? For patients with HER2 mutated non-small cell lung cancer, I think the biggest and most awaited trial right now is DESTINY-Lung04, which is Trastuzumab Deruxtecan versus chemotherapy plus immunotherapy in the front line, and seeing what the efficacy is going to be of that agent and sort of compare that with zongertinib. For patients with EGFR mutations, the Datopotamab Deruxtecan story, I think, it's pretty clear the activity there for this patient population, but we're still interested in understanding with the QCS and MR biomarker, are we going to see Datopotamab Deruxtecan in the front line for patients without driver alterations in combination with chemo, other agents, targeting other targets, like we've seen bispecifics come in front line, and so we're seeing these combinations emerge, and I think that's really exciting to see as well.
I'm so glad that you mentioned the combination point as well, because I can't leave before mentioning combinations in breast cancer as well. And we've seen data for ADC plus immunotherapy combination in triple-negative breast cancer. We have data earlier phase, but data for the combination of Dato-DXd with immune checkpoint inhibition, and an ongoing phase 3 trial will hopefully provide confirmatory data for our patients with PD-L1 positive triple-negative breast cancer. So I think another exciting future direction. Well, I want to thank you, Dr. Leal, for this great conversation. I learned a lot about lung cancer, and I think it was an exciting way to compare the developments in breast and lung cancer, specifically in terms of antibody-drug conjugates. Thank you.
Thank you very much, and I, the same, learned a ton about breast cancer. And I think it's really exciting to also learn from each other, including like the safety, the sequencing. Like we can borrow a lot of the knowledge that we have from each other to kind of continue to advance the field. So thank you very much for today.